good morning. Tante tinggi ke? Otherwise cannot see me, is it? Yeah. Wow, tinggi. Right, okay, me again. So, now, this topic is approach to pelvic organ prolapse. So, you're not going to expect to get any evidence-based guidelines or very hardcore theory from me, right? Basically, is how to approach when you're given a case that you suspect pelvic organ prolapse in your clinical exam, in your short cases, or even in essay or CTC, right? So this approach can be applied to most of it. Just sit down and listen and don't need to copy anything. So what are the things that you need to know when you are approaching a case of pelvic organ prolapse or you are sitting for a theory exam? So these are the things that I'm not going to go through with you. I expect you guys would have your own textbook, internet, notes or whatever. Okay, so make sure you know all this before you come in for your exam. Number one, what is prolapse? Definition, semua tahu kan? Tak payah saya repeat lah kan? Right? Number two, you need to know what are the compartments that is involved. Right? Is this patient having an anterior prolapse alone? A posterior prolapse alone? Having central or apical prolapse alone? Or in combination, right? And very important thing, is she still have a uterus or not? Right? One of the past exam that during observed long case, patient complaining of something coming down from vagina, but the candidate did not even ask any surgical removal of uterus. Okay, be very, very careful on that. Okay, a wart prolapse management and a uterine prolapse management is totally different. So your history taking has to be included on that, whether she still have a uterus or not. Again, know your pelvic anatomy. Okay, well, we are not going to draw a pelvic bone and muscles for you to identify. This is undergraduate, unless you are dealing with OSCE, right? No point in it. You're sitting for postgraduate clinical exam. But in situation where you are dealing with a long case or short case, okay, if your examiner is slightly unhappy with your answer, we are going to think, am I going to pass you or am I going to fail you? Right? Most of the time, we're trying to ask very, very basic questions, including anatomy, normal physiology, normal biochemistry. So if you can answer, probably we will give you a just passed, right? If you cannot answer anything about anatomy, normal physiology, or whatever, it's a good reason and good excuse for us to fail you, isn't it? We don't have to justify anymore because you don't even know anatomy. Betul? Right? So go through your pelvic floor anatomy, pelvic organ support anatomy in and out before you come in for your long and short cases. This one, everybody takut. Everybody worried, right? Especially when see my face. As if I got a chop you on my face. Betul? Right? I remember I took clinical exam, short case, you know. Yes, memang pelvic organ prolapse. I tak tanya apa-apa pun. I just examine this patient. Start talking about POCQ. AA lah, BA lah, whatever. Padahal saya nak dia tunjuk ada prolapse ke tidak ke saya. Right? What you need to know is basic examination technique. Right? Simple examination technique that can demonstrate there is a uterine prolapse, there is a cystocele, there is a rectocele. I dah pass you dah. Alright? I don't even need you to do AA, BA, C, whatever. Okay? But because of that, candidate keep on talking about AA, BA, despite me asking about simple technique. Aku tanya tanya satu soalan je. Demonstrate your point D, gone case. Right? When you ask for it, you got it. So don't open your mouth or talk about POPQ unless the examiner asks you. Faham tak? Okay? My tricks to you. This one, everybody knows? Level 1, level 2, level 3. Okay? Keep it in your mind. You may be asked, right? Especially in clinical exam. Okay? Now, another thing that you need to know is the etiology, the risk factors. Okay? Definitely pregnancy and childbirth is the most common risk factor. Keep it into your mind. When the examiner asks you, why do you think this patient is having prolapse? Or actually having wart prolapse or recurrent prolapse? Why do you think she is having wart prolapse or whatever? Number 1 on the list is always childbirth and pregnancy and then aging. Don't go and think yang bottom on the floor punya Ehlers-Danlos syndrome and then come the first in your mouth. You know what is the feeling of your examiner? You understand or not? Alright? Unless you're dealing with a very, very young teenager ke, 20 ke, 30 ke, then you talk about potential, maybe she has some congenital abnormality. And that is very, very, very rare. For us to be able to get you one case congenital problem in a clinical exam, you must be very, very lucky. Huh? Lucky to pass or lucky to fail, I'm not sure. Alright, always remember the acquired is the most common. When you want to give the risk factors or causes during your clinical exam, the top always go first, right? Now, always remember when you are, especially now you guys, the new curriculum, you are going for observe long case, right? You are going to clerk the history and examine the patient in front of the examiner, right? Whatever nonsense you ask, we know, right? Whatever information you get or you don't get, we know. You cannot cook it up anymore, right? Now, very important, a lot of time, you still have this common mistake. You try to clerk a case just for the sake of making a diagnosis. That is wrong. Postgraduate level, you guys are already a doctor. Alright? Making a diagnosis is undergrad, is professional exam undergrad final year. Okay? Your level, all questions being asked other than making a diagnosis. The question is leading to your formulation of plan of management, short-term plan and long-term plan. Alright? So you need to take into consideration of patient's concern, what patients wish, for example, all those kind of things, so that when you answer your examiner, I am planning to do this because I have discussed with patient and this is the best for her, something like this. Alright? So, you punya history, you punya examination have to justify for us that this is your plan. So your history taking is not just about making the diagnosis. And that is a lot of mistake being done during recent mock exam. Okay? You all only come into diagnosis, lupa actually I mau plan untuk management. Faham tak? Okay? So, for example, let's say you have a case, you are doing a vaginal hysterectomy, no, you are planning for a colpocrisis. Lepas tu dia tanya you, patient sexually active ke? Alamak, I lupa tanya. Something like this. Alright? Understand? So, now, when you clerk a history, these are the things that you need to consider. This is not a full list, yeah? This is something very important that you shouldn't miss. Age. Why age is important? Number 1, am I dealing with a woman in reproductive age, childbearing age? Am I dealing with someone perimenopausal? Am I dealing with someone postmenopausal? Or am I dealing with someone severely old? Nampak tak beza dia? Childbearing age, I'm thinking of, am I still need to preserve her fertility? My management will be different. My plan will be different. Her fitness would be different. The way your answer is here, 30 tahun sama dengan 80 tahun. Tak ada beza. A 30 years old, do you expect her to be very, very ill? Right? No, right? So the way you write your essay, the right way you write your plan of management, what do you need to consider is different from when you're dealing with someone with 80 years old. Right? So the age itself will determine what is your next question, what is your plan of management, what are you going to examine. Right? Clear? Now, what would be the presenting complaint when you're dealing with pelvic organ prolapse? A lot of time, during mock exam, your question is only ada rasa benda keluar ke tidak. But what are other complaints? Backache? Tak tanya. Any frequent ulceration, bleeding? Tak tanya. Right? Does she need to reduce the mass to pass urine? Tak tanya. Does she need to reduce the mass to defecate? Tak tanya. Right? Does she have incomplete voiding? Tak tanya. All these kind of things not asked, but you only ask about, do you feel a mess? That's all. Does it affect her sexual activity? Tak tanya. Very rarely you guys ask about this. Okay, the presenting complaint. Not only the chief complaint, the main problem, but as you all know, pelvic floor dysfunction associated with other symptoms like urinary tract symptoms, bowel symptoms, right? Even affecting the sexual life. So all this has to be stressed and asked. Faham tak? Right? And your management also largely depending on patient symptoms and not the disease itself. If you just have a stage 1 prolapse patient, happily nothing, no urinary tract symptom, no sexual problem, everything, she doesn't feel anything, just because you do a pap smear, you see a stage 1 prolapse. Now you shove in a pessary. Justify or not? Nampak tak? Okay? So, presenting symptoms, what is her concern? And again, remember the risk factors and contributing factors. A lot of time, what we want to know is there any reversible kind of things? Childbirth, pregnancy, aging, no choice. Alright? But if your patient having chronic constipation, for example, if your patient is having chronic cough, all those kind of things, always remember your management have to include that. Because optimization of all those risk factors is one of the key to prevent recurrence. And you have to talk about that either in your CPC, in your essay, or even in your clinical exam. Faham? Right? Now the next thing is I put there clinical hurdles. I don't put there comorbidities. Alright? It's not just about comorbidities that will affect your plan of management. Right? That's why I put there clinical hurdles. And again, pelvic organ prolapse is not something, if you don't treat, she will die, right? Unless secondary complication happen. It's more about quality of life. This one you have to assess. You have to check, especially when you are in your observed long case. How much does it affect her physical activities? How much it affect her social life, mental, sexual, right? Everything about it. You have to ask about. And because how aggressive if your management is also depending on how much it affects the patient and which symptoms actually affecting her most, right? Again, don't forget, remember I said, ada student lupa tanya patient sudah hysterectomy ke tidak, right? Previous treatment and outcome. Sometimes patient may have already had a ring pessary on board, or she might have failed pessary previously, and this is not asked, right? So, and what kind of symptoms resolve after the treatment? What kind of symptom persists with the treatment, right? Persist doesn't mean never improve, okay? Sometimes when the treatment is given to a patient, the symptom persists, yes, but there is improvement. So those are things that you need to take into consideration when you want to decide on the plan, right? And if, let's say, she had a vaginal surgery before because of prolapse and now recurrent, you need to know the interval. You need to know what actually making it come back, right? So, and what is her expectation? That is very, very important. What is patient's expectation, especially when you are dealing with an observed long case, right? You need to communicate with your patient so that When you want to inform your examiner, this is my plan because I have already explained, I have already discussed with the patient. And not your own plan of management. Always remember that you are not God. You don't determine what patient needs, right? Two-way communication, patient's involvement is what we want to see. Okay, so this is just another diagram showing you what I've mentioned. Again, when you take a history, when you talk about, when you want to plan your management during your CPC writing, all these things need to be considered, right? Whether patient is asymptomatic or symptomatic. Does she only have prolapse symptoms or other related symptoms, for example, urinary tract, bowel, all those kind of things? Okay, your management, your plan will be very much different. And what things that she bother most? Yeah, what she concern most? All right, and sometimes you may see a patient doesn't complain anything despite having a stage 4 prolapse. Am I not doing anything, or am I going to do anything? Another thing that you have to assess is there any other secondary complication, right? A stage 4 prolapse may give you a kinking ureters that will lead to hydronephrosis, for example. That if the patient doesn't want treatment, also you have no choice but you need to treat. Okay, look for all those things. Clinical hurdles other than comorbidities. Comorbidities basically will make you determine whether you are going for more conservative plan. If you want to go for a surgical plan, can your patient fit to that particular long surgery, or you want to go for more conservative surgery? Her desire of fertility, if you are dealing with a younger patient, for example, you always get a patient, for example, 35 years old, only having one child, now having prolapse because of a big baby, a vacuum delivery, for example. How are you going to plan? Okay, the desire of fertility is important. This is a clinical hurdle to you. She may have a stage 4 prolapse at the age of 35. We have seen that, right? But she wanted pregnancy. So what are the things that you need to consider? Desire of sexual activity. Don't always think that makcik 70 tahun, they are not sexually active. Okay? We do see patients come for surgery just because they are sexually active and the prolapse actually making problem. Okay? So desire of sexual activity and how much this prolapse causing her unable to have sexual activity. Is it because of pain? Is it because of fear? Or is it because of what? Right? You need to know the reason. When the makcik said, at the moment I'm not sexually active, is it because of the prolapse that you are not sexually active? If I treat your prolapse, are you going to be sexually active back? This kind of question you need to ask. Alright? And what are the confounding symptoms? For example, I've mentioned many times, urinary symptoms, bowel symptoms, etc. Okay? Again, stress on patient's choice. You may think the best for her is this plan of management. But the patient tells you, I want this. I want the other one. So this would be another hurdle for you, and you need to justify, you need to put forward what is the benefit if I do this, what is the disadvantage if I do that. You need to counsel your patient properly, adequately, so that she understands her choice is not the first choice, but we respect your wish, and you have to understand this may occur. And if you develop whatever things that I have mentioned, are you willing to go for the other choice? Right? So this would be some things that you need to consider, you need to clark when you are doing your observed long case. Examination, I'm not going to go through that. Right? Now, decision of management, again, very, very largely depending on patient's age group. Like I said, reproductive age girl, perimenopausal girl, elderly girl or severe elderly girl, how fit is she? What is her major concern, right? How fit is she? And the other thing is the stage of prolapse. You all always like to write in essay. Yeah? Kegel exercise is a first line management, blah, 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 blah. If this one fails, then only I do this. But the question gives you a stage 4 prolapse. What do you think? Kegel exercise is a first line management. Is that so? Does it work? It doesn't work, right? So your justification is not there, right? The stage of prolapse. And what are the compartments involved, right? Again, stress on this. Has this prolapse been treated before? Successfully treated and recurred, or never successfully treated, right? And what are the potential complications that may happen after the surgery? Okay? And again, whatever plan that you are going to do, you need to assess what is the risk of recurrence. Okay? So basically, this is how you're going to approach. Either you are giving a short essay, CPC, even clinical exam, right? So conservative versus surgical. You try sparing. Are you planning for any additional procedures? For example, if your patient is having incontinence, are you planning to go for incontinence surgery? If yes, why? If no, why? Okay, there is always two schools of thoughts, right? Some believe that you should go together, do the incontinence surgery together with your prolapse surgery. Some will decide no, go for interval. And there is no answer called usually we do this. When you start to answer the word usually we do this, we know that you don't know. We always individualize patient. Don't try to cut off this word from your brain. Usually we do this. This is a very, 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 very wrong answer. Okay? One patient with prolapse, with incontinence, I might do 2-in-1 surgery for this particular patient because of certain reason. Another patient, I might decide to do the other way around because of certain reason. This always suits the patient. So individualized patient is very, very important. Alright? Again, in your essay, in your CPC, always tailor your plan of management to that particular patient profile. When you think that this is not suitable, write it down why I think this is not suitable. Justify it. Alright? Okay? And again, especially if you are dealing with a stage 3, stage 4 prolapse, you need to have a plan of how am I going to prevent what recurrence. Am I going to do a native tissue repair? For example, you do a SSF, you're going to do a macrocoloplasty, or why am I not using a mesh? Okay? That's all, thank you. That's why I said, no need to copy anything. Okay. Any question? Very short, right? Huh? Yeah, my only approach, how to approach only, It's so easy, this job. Okay, any question?
Any questions from the floor?
Ada?
Check.
Alright.
Check. Prof, there is question online, Prof.
Ada online pula?
Prof, dia
Tak berani nak tanya. Sebab
Second.
apa? Okay.
What if a 30 years old Parawan came for clinic review for her second pregnancy asking for caesar in view of she has cystocele stage 1 and clinically asymptomatic? How to approach this patient and manage her?
Who tells her she has cystocele in the first place? Huh? Besar mulut cikgu, besar mulut doktor tu buat spectacular nampak ada cystocele dah ni. Baru stage 1. Tak common ke? Do we need to manage that? She's now second pregnancy. Her first pregnancy is childbirth is what?
Did not mention, most likely SVD or
Tak boleh presume
did not mention in the question. Siapa yang tanya?
Now, you all cannot presume she has vaginal delivery. You cannot presume like this. You need to get a further history about any previous birth trauma, not before she so consider that stage 1 cystocele having a asymptomatic mau buat caesar, right? is she requesting cesarean section for the prolapse or because she has some traumatic experience? So Ananta complete. Right, no. Now she's young, right? You know that pregnancy itself is already a risk factor for prolapse. And any woman after a vaginal birth, cystocele stage 1 is relatively common. And most of the women stage 1, they don't feel anything. Right? It's very, very unlikely she noticed it unless a doctor actually mentioned to it. And psychologically, she start feeling it. Right? Now, answer to cesarean section to prevent further cystocele, perhaps, I would say no, but I cannot deny the patient, right? Number one, pregnancy itself, not only the childbirth, can cause prolapse. The 9-month pregnant, right? So you need to get further information about her previous pregnancy, her previous childbirth, birth weight, any complicated delivery or not. Right? Other than the so-called stage 1 prolapse, she doesn't feel anything. Does she experience any incontinence or not in terms of urinary incontinence? That is very common after childbirth. Right? Now, some women having transient SUI after childbirth, right? But it disappeared slowly. Right? So we can always tell the patient, well, I cannot deny your cesarean section. You need to understand the risk of going through a cesarean section. It doesn't prevent 100% prolapse, which already there, right? But vaginal delivery is never a contraindication for this kind of case. Okay, yes, it may further worsen the so-called cystocele from asymptomatic becomes symptomatic, from stage 1 becomes stage 2, for example. What you can always advise her is Kegel exercise, all right? A good lifestyle, right? As well as do not increase the weight so that it prevents it. Whatever you can do is prevent further prolapse, but the childbirth, well, I'm not God, right? So vaginal delivery, definitely there is always a risk of worsening whatever stage 1 that she has, making asymptomatic become symptomatic. That one you cannot deny, right? So I cannot refuse her cesarean section, but it's always laid down what is the pros and cons if you go through vaginal delivery, what is the pros and cons after the vaginal delivery. And again, assess this current pregnancy. If she's still in early pregnancy, it's too early to say the rest of the thing. You wouldn't know that this pregnancy will develop anything that is contraindicated for vaginal delivery anyway. Alright? So those are the things that you also need to consider before you make a conclusion that I would grant her a cesarean section, or I said no, you must go through a vaginal delivery. Nowadays, vaginal delivery also practicing consent, you know. Right? Okay?
Prof, another question. We have another 3 minutes. So last question. How to manage a patient with stage 3 UV prolapse in pregnancy?
Do you think she will still have stage 3 when pregnant? Do you still think that she has stage 3 in pregnant? Most of the time, the prolapse will actually resolve when the pregnancy progresses. We do have seen patients with stage 2 prolapse needed a ring pessary during early pregnancy, but by second trimester, right? She doesn't require the pessary anymore. All right. Now the weakness is pelvic floor muscle, not cervix. So this not commonly you will see cervical incompetence, right? I remember 3-4 years ago we do have a case in long case, and I was partner with Prof. Nick Zaki. Alright? There is a problem when this particular woman go through labor. There is a problem when this patient go through labor. there may be labor dystocia. Because when labor progress comes, right, when the head descends and need to rotate, you need to have certain pelvic muscle tone, the resistance to facilitate the rotation of the head. So there is a possibility when the pelvic floor muscle is so lax that there is failure of rotation of the fetal head according to what you want. So there might be what you call this labor dystocia because of that. Alright? But the thing is, we do not advocate elective cesarean section, especially if she is already multiparous. You can give a try, but watch out for labor dystocia, prolonged labor. Okay? And the student failed to answer that. That is what Prof. Nick Zaki wants the answer. Well, don't say because she already has stage 3 prolapse, I want to prevent further prolapse, I want to do a cesarean section. This is a no-no. This is similar to when you have already a severe anal incontinence because of a 4th degree tear, for example. You want to do a cesarean section to prevent further deterioration of symptoms. That is a no. Right? So most of the time you allow vaginal delivery and you repair after completion of childbirth, for example. That is safety. Sudah 3 minit lah.
Yeah. Any other question? No. Alright. The floor would like to thank Prof. Lee Pei Shan for such an eye-opening lecture on approach to therapy of the products. So next up, we will have a lecture on menopause hormonal therapy, and emphasizing on tackling special population and malignancy will be given by none other Associate Professor Dr. Eng Beng Kwang from Universiti Kebangsaan Malaysia. He is our Senior Consultant ONG, Clinical Lecturer, with special interest in menopause hormonal therapy. Let's listen from the expert itself. The stage is yours, Prof. Eng.
Thank you. So topic is not that tall, because starting from depths. I do not do depths. Okay, good morning everyone. So